Thanks for joining me. This is Molly Lombardi. Once again, this is our final slide on this is on peptic ulcer disease, and it'll conclude our gastrointestinal system slides. If you have questions, you can always email me or stop by my office. For this section, like I said, we're going over the peptic ulcer disease. We're going to start off with an overview. Then we're going to head over to complications, which include hemorrhage, perforation, and gastric outlet obstruction. We're going to look at common medications, post-op care, then post-op complications, and wrap it up with client education. Peptic ulcer disease is the erosion of the GI mucosa from the gastric acids that are usually used to break down foods. It can occur in the lower esophagus, stomach, and duodenum, but really can occur anywhere the gastric content is in contact with the mucosa. It can be acute or chronic. Acute has minimal involvement with a short duration and the ulcer resolves quickly, whereas chronic is much longer duration and it may erode the muscular wall and form some fibrous tissue there. It's usually a lifelong problem, and the chronic condition is more common than the acute. The main cause of peptic ulcer disease is from a bacteria called H. pylori. It comes into the body through the oral fecal route in childhood, and it usually stays there colonized until adulthood, where it later interacts with the gastric secretions and results in the peptic ulcer itself in the lining. Another cause of peptic ulcers are medications, specifically aspirins and other NSAIDs and corticosteroids. Along with the medications, another cause is habits like alcohol consumptions, coffee, and smoking. There's two types of ulcers. There's gastric, which is found in the stomach and is less common. Usually the client will have epigastric discomfort after meals, where food will aggravate the condition. Then there's duodenal, where this is more commonly caused by the H. pylori bacteria. And in the duodenal ulcers, the client will have discomfort once the stomach is empty, so food is usually a buffer. The client will complain of burning and cramping in the mid-epigastric area and also back. The diagnosis for peptic ulcers includes an endoscopy, an upper GI with barium, and then usually a CBC will also be done to assess for any bleeding associated with the ulcer. Bleeding can occur with peptic ulcer disease. More commonly, bleeding and hemorrhaging will occur with the duodenal ulcer. The image on the top of the slide shows a bleeding ulcer in the stomach, but I want to point out that the duodenum is where I put the arrow. It's right past the pyloric sphincter, which we learned about in the pediatric section of the GI disorders. So with many of these clients, they're going to be NPO because you don't want the bleeding to be aggravated by any foods that's ingested. An NG tube may be inserted to decompress the stomach, and the client is going to require IV fluids for replacement, seeing how they're not able to ingest anything. The nurse will want to record strict I's and O's, including the NG output. And then, of course, whenever a client is NPO, the mouth care or oral care is even more important because they're going to have a dry mouth. Ensure that the nares are clean and patent. You want to assess vital signs, and this is important especially because you want to closely monitor for excess blood loss, which can lead to shock. So one would see an elevated heart rate and drop in blood pressure if shock was occurring. Monitor lab values, especially the CBC, which has the H&H, the blood counts, red blood cell counts, and also monitor the electrolytes, because we're pumping out the stomach if they're on decompression, and that can lead to electrolyte imbalances. So most peptic ulcers stop bleeding without surgery, but we're going to go over surgical interventions on a later slide. Another complication which is very serious is a perforation. There's a high mortality rate associated with perforations. Underneath this, you'll see peritonitis, which we've talked about in great length, and this may occur after a perforation. I've been talking about peritonitis with bowel disorders. So you should understand by now that peritonitis, when talking about a peptic ulcer disease, is when the ulcer perforates the wall of the stomach or duodenum and the contents leak out into the peritoneal cavity and then cause an infection. For the visual learners, I've included this picture on the slide. It's a wonderful way to get a good sense of what peritonitis is, no matter what the cause. Nursing assessment will include frequent vital signs, and they're likely to show a fever, increased pulse, and initially an increased blood pressure because of the pain. And later, if shock occurs, the blood pressure will decrease. A hallmark sign of peritonitis is a sudden onset of the upper abdominal pain, and it's going to radiate to the back and shoulders. You may also see a board-like rigid and distended abdomen that has rebound tenderness. You'll auscultate for an absence of bowel sounds. And because the abdominal distension is pushing up on the diaphragm, the client may also have shallow and rapid respirations. Treatment includes keeping the client NPO. Then you'll need IV fluids for hydration. An NG tube might be placed for decompression. IV antibiotics are likely. And they may need surgery to remove the fluid and repair the area that was perforated. Another complication is gastric outlet obstruction. This occurs in the distal stomach and the duodenum. It's caused from edema, inflammation, spasm, or scar tissue formation that obstructs the outlet where the stomach content would normally drain from the stomach into the duodenum. It makes me think of the pyloric stenosis babies because the problem is occurring in the same area of the GI tract, so it's no surprise that the client with gastric outlet obstruction has projectile vomiting. Management may include an NG tube for decompression with irrigation. Then, as the nurse, you're going to measure and record the gastric aspirate. And then prior to removing the NG tube, it's common to have an order to clamp the tube for a period and then measure the aspirate to get a sense of how much gastric content was able to pass through the pylorus. So if the client has a relatively small amount of aspirate, the fluid would be reintroduced and the diet would be advanced. Typically, you begin with about 30 mLs an hour, and then you're going to check the gastric residual. If there is a buildup more than the 30 mLs an hour, then it wasn't successful and not much fluid at all passed through. Whereas if you put in 30 mLs and you only get 10 out, that's an indication that things are moving through that sphincter. So as the client progresses, more fluid will be introduced slowly and it will progress the diet from there. So when doing this, of course, you're going to need IV fluids running for the client because they're going to be NPO for some time, along with electrolyte replacement as needed. If bowel rest doesn't reverse the inflammation or edema, or if the client was experiencing gastric outlet obstruction caused by scar tissue, the surgery might be needed. You can see in the picture on the bottom of the slide where the surgical intervention is to remove the distal distended part of the stomach along with the duodenum and attach the small intestine to the stomach, bypassing that sphincter part. These are the remainder of the medications on your objectives page. The goal here is to either reduce the gastric acid secretions, which is causing the peptic ulcer, or to protect the lining of the mucosal membrane. We start with omeprazole, which is also called Prilosec, which is either prescription or over the counter. It's what we call a protein pump inhibitor, and it acts by reducing the gastric secretions, thereby healing the primarily common duodenal ulcers. Clients that take this medication can experience C. difficile associated with diarrhea and abdominal pain. So as the nurse, you would want to monitor bowel function, also the PT-INR or clotting factors, and a CBC. The next medication is ranitidine or Zantac. This is a histamine H2 receptor blocker, and this acts by inhibiting the action of the histamine, which results in decreased gastric secretions. The more important side effects or adverse reactions are, particularly in the elderly, is confusion, arrhythmia, and anemia. So this medication may not be the best for your elderly clients. Nursing implications include the safety, which is related to the elderly client, and you also want to monitor for CBC for bleeding. The last medication is a cytoprotective drug called sucralfate or carafate. This drug works by forming a thick paste that adheres to the ulcer surface like a coating for protection. The adverse reactions and side effects with this medication include constipation, dry mouth, and anaphylaxis, which is a severe allergic reaction. It's life-threatening. Nursing implications include to encourage your client to drink adequate fluids to combat that dry mouth and constipation. Also to administer this on an empty stomach before meals at bedtime, and that way the stomach is empty and it can coat it better. And to encourage them to continue the therapy for the usually prescribed 4 to 8 weeks. So what sometimes happens is when clients start to feel better, they stop taking the medication, but we want them to continue it for the full length of time so that way the mucosal lining can heal and the ulcer will hopefully be gone by then. Sometimes surgery is required for clients who don't respond to the medication and bowel rest. There are a few procedures that your textbook talks about. The first is a partial gastrectomy, which is the removal of the distal portion of the stomach or the lower portion of the stomach, and then it's attached to the duodenum by reostomosis. This is called a Billroth 1, and this is shown on slide number 6 that I already went over. The same procedure, but in an ostomosis to the jejunum instead of the duodenum, is called a Billroth 2, and this is shown on the top of the slide here, the top picture. A vagostomy would be when they sever the vagal nerve or the vagus nerve, and this decreases the gastric secretions, and this is shown on the bottom of the slide here. And finally, there's a pyeloplasty, which is a surgical enlargement of the pyloric sphincter, which would facilitate the passage of content out of the stomach. It's similar to the procedure shown in the pyloric stenosis section of this content. So nursing care of post-op patients would again include placement of an NG tube for decompression and bowel rest. You would maintain patency of the NG tube through irrigation. And this is important because if the tube is not patent, then there can be a buildup of gastric content and it'll increase pressure, which could lead to the rupture of sutures and potentially a perforation. You would observe the color of the aspirate. And initially, it might be bright red blood post-op, and then the blood will darken, and the content should turn into a yellow or green color, which is normal. An abdominal assessment would focus on the presence of any distension, discomfort, or peristalsis. We would focus on pain management. Just like any other post-op patient, we would administer analgesics. We would change position frequently. We would teach splinting of the area and also do coughing and deep breathing. We would observe the dressing for bleeding and signs of infection. And we would promote early ambulation to prevent any complications. IV therapy would be going on, and it would usually include potassium and sometimes other vitamin supplements, because remember, we're taking a lot of their gastric content out, and that can lead to electrolyte imbalances. This is typically short term, so we typically wouldn't be doing any parenteral nutrition, we would just be doing this for short term, do IV fluids, and then advance their diet from a clear liquid to a regular as they tolerate it and after the NG tube is no longer necessary. Complications that can occur after surgery, they are going to include bleeding, of course, and then pernicious anemia, which is when you don't get enough vitamin B12, and this is mostly due to malabsorption issues. Another serious condition that can occur is called dumping syndrome, and within that is something called postprandial hypoglycemia. So when this happens, it's because the lower portion of the stomach was removed, including the sphincter that controls the movement of gastric content into the duodenum. Due to that loss, there's no control of when that content empties into the duodenum. So as pictured here with the dump truck, food goes into the stomach and suddenly dumps into the duodenum. And when this happens, it causes a gastric distress, including pain, weakness, diaphoresis, dizziness, and that sudden increase in volume can also cause an increased need for the body to produce more insulin. So the body kicks in and produces a large amount of insulin when the food is gone into there quickly, and then there's too much insulin in the system and the client becomes symptomatic and hypoglycemic. So this is a nice picture to look at, and the only discrepancy is it says that this occurs about 15 to 30 minutes after eating, and I'm pretty sure your book says it's an hour, but that's okay, it's still a good image. So what we want to do is encourage clients to have small, frequent meals and not drinking a lot of free fluid with their meals to avoid that increased volume. So not eating a lot of carbs is another thing that you should instruct them to do, but eating moderate intake of proteins and healthy fats is a better option. So the other issue, another complication that can occur is bile reflux gastritis. And this is kind of the same problem, but in the opposite direction. It's the picture on the bottom left of your slide. So what happens is the esophageal sphincter on the top of the stomach is either gone or damaged, and so the bile can flow up more freely from the stomach into the esophagus, where it causes irritation and erosion. Once clients with peptic ulcer disease are treated, whether it's through surgery or medication management, it's important to concentrate on our teaching. Your textbook has a great table for client education that I listed on your slide, so make sure you go over this as well. Our goal is to prevent reoccurrence of any conditions. So we would want to work with other people in the team, such as dietitian, for any modifications and a nutrition plan. Again, we want to focus on small, frequent meals with low carbohydrates and a moderate amount of fat and protein with limited fluids with meals, especially if a portion of the stomach was removed through surgery. Medication education would have to take place, including the over-the-counter medications. We would make sure that we would have all of the medications listed on the med rec and then the patient understands when to take them and their frequency. Smoking cessation is essential because smoking irritates the lining of the stomach. So screen your patients when they're admitted and also before they're discharged home. Coping strategies, because stress can increase the gastric acid secretion. So making sure that they have the adequate strategies for going home with. And we want to teach them about reportable symptoms, so when to call the healthcare provider. And these can be an increase in nausea and vomiting, increase in epigastric pain, any bloody emesis or tarry stools. We would evaluate our care with our clients, and for example, this might be making sure their pain was well managed, making sure they can verbalize or in some form understand their treatment regimen, and if they're willing to commit to their plan of care, and if they've demonstrated an absence of complications. So you see the elderly clients again on your screen. Remember that concerns here that are specific to the elderly is that they often take NSAIDs for arthritis. So, of course, NSAIDs contribute to peptic ulcer disease. We would want to make sure that we provide education to them on all the medications and their side effects, including the over-the-counter meds. This concludes the voiceovers for gastrointestinal disorders. Thank you for staying with me for all of this. Make sure you look at your textbooks, and I will see you all in class for an exciting discussion.